I'm going to share with you. Well, let me finish this. And as I've had to been involved with consultation or thinking about the care of people that have not responded or gotten good results from treatments that theoretically work based upon what is called evidence-based medicine, then I've had the need, I think, to think about, read about, consider, and sometimes, when appropriate, recommend treatments that are, some might call esoteric, or things that are published in medical literature that seem to be relevant but don't get, like, that are off label and not publicized. The story of how I came about reading and learning about ketogenic diet is relates to my days as a working at a state hospital in rural Oregon. And a couple of things happened. One, there was a medical error, a medication administration error. Apparently, one of my patients had been struggling, not achieved really great symptom relief with things that had been trying to treat him with. Was inadvertently given Depakote. I'm going to use the name Depakote because divalproic sounds, well, because there are several variations of valproic acid in treatment. He'd been given Depakote inadvertently. Took a relatively, I mean, like a fully therapeutic dose for somebody else. Luckily, it wasn't excessive for this particular patient. But he was then asking for that pill that he got last night. The nurses were showing him the pills that were ordered for him. He says, no, 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 nothing. These weren't the ones. And ultimately, it was discovered that he received a like 2,000 milligram dose of Depakote from some other patient. But he was in fact remarkably better. And that got me thinking, as I left the hospital that day, how often um, I have used anticonvulsant drugs and seen them work in people with schizophrenia-like illnesses and other conditions, and was thinking about, just musing, whether there might be ways of achieving anticonvulsant benefit without the risk of anticonvulsant drugs, or would there be we could say kinder, gentler way of reducing brain excitability? And then that's when I realized, oh yeah, I read a long time ago that the ketogenic diet had been used to treat epilepsy. And as far as I could recall from the last time I read, it was still being used in the treatment of epilepsy. And so I got to wondering, if ketogenic diet is effective as an anticonvulsant treatment, and if many anticonvulsant drugs are effective as psychotherapeutic agents, then could it be possible that a ketogenic diet might have benefits for people with schizophrenia type illnesses or bipolar type illnesses? So I started reading about things, and there's a little bit of a signal here. So I'd like to talk to you about ketogenic diet for severe mental illness. As I mentioned, it was in fact, and still is, used as a treatment for epilepsy. It was developed for pediatric epilepsy in particular, and if it's used at all, it's still usually used for those cases. Typically, it's used for pediatric epilepsy that has not responded to standard anticonvulsant drugs. It is, I think, unquestionably effective, although obviously something of a challenge to implement and maintain. But it is a bona fide anticonvulsant treatment. And as I said, bona fide anticonvulsant drugs like Depakote, carbamazepine, and others we use widely. The other thing that I think, the other consideration that I think is important, or that leads to looking at the psychiatric use of ketogenic diet, has to do with the fact that a lot of psychotropic medications, particularly the second generation antipsychotics and several of the anticonvulsant drugs, are really quite disastrously bad in terms of what is euphemistically called metabolic side effects. That translates into sometimes very substantial weight gain with severe dysregulations of control of glucose levels. And that leads to a cascade of events, which ultimately are tightly associated with decreasing the lifespan by something up to 20 years, according to some estimates. And I'm going to just digress slightly and talk about the weight gain risk from antipsychotic drugs. Um, the from my reading of psychiatric prescribing culture or general ethos in the profession, it is seen as barbaric, perhaps to prescribe a medication like haloperidol as a first line treatment for somebody with schizophrenia. Um, we have defaulted to recommending as a first line treatment any of the atypical or second generation antipsychotic drugs, which are drugs which have generally speaking, substantially elevated risk for dysregulating metabolism, causing weight gain, causing hyperglycemia, causing diabetes, and so forth. The rationale, and since my career has spanned the transition from first generation to atypical drugs, the rationale for preferring these second generation agents is substantially based on a belief that they will reduce the risk of tardive dyskinesia or perhaps eliminate the risk of tardive dyskinesia. And they certainly have a lower overall risk of acute extrapyramidal symptoms. And tardive dyskinesia, if established, does have between a 30% or 50% likelihood of remaining permanent. So that was a reasonable rationale. But here's the counter argument. In protecting people from neurological side effect risks, we are, by systematically prioritizing second generation drugs, prioritizing that our patients with severe mental illness get diabetes or severe overweight, which can lead to side effects or complications such as stroke or heart attack, which are absolutely 100% irreversible and not infrequently fatal. So then I will leave it to the audience to wonder whether that's a good deal to prioritize, to try to minimize the risk of extrapyramidal side effects, which we can very often treat with medications like amantadine or benztropine, or through simply using lower doses, in exchange for inviting risks that are absolutely irreversible and quite morbid. And then one other editorial thing, it's unfortunate that medicine in general and the psychiatric profession in particular has not done a better job of instructing its practitioners about how to prevent or minimize weight gain risk from psychotropic medications. In fact, in many programs, I don't think trainees are given any advice aside from the standard recommendation of try to have a better diet and exercise more. And I will just point out, again, to be a little bit snarky, but to try to make a point, that I have, according to the tests, above average intelligence and fairly good financial resources. And if I want to lose weight, I can very easily hire personal trainers, have special food brought in and all that stuff. And most of my friends, have the same abilities. And most of us cannot lose substantial amounts of weight and keep it off for the long term through diet, exercise with available support and our big brains. And me and my friends struggle to lose weight and keep weight off. And we do not have doctors that are recommending that we take medications which pharmacologically put our appetite into overdrive and at the same time cause our insulin response to shunt glucose into fat storage. So I think it's a bit unfair or naive for those of us who prescribe, say, Zyprexa, to then tell our patients, well, try to eat less and exercise more, when that is a strategy which, for most people who have good resources, often fails. And we are, again, pharmacologically augmenting appetite in unnatural ways and making the person's ability to dispose of glucose very much impaired. So, pointing out that weight loss or weight gain is, I would say, one of the biggest unaddressed problems that cause substantial damage to our patients. And I'll leave it at that. But going back to ketogenic diet, its ketogenic diet stands out as a possible mechanism to perhaps better prevent or reverse antipsychotic induced weight gain. This is because with ketogenic diet, for most people, it is possible to run a caloric deficit of 100, 200, 300 calories a day and not eventually stimulate a hunger response, which will, blow the diet apart. And then these drugs, by and large, are responsible for or contribute to abnormally elevated glucose levels. And with a ketogenic diet, very little glucose goes into the system, or very little carbohydrate goes into the system, and thus very little glucose in excess is made. So ketogenic diet might be perhaps the smartest way to minimize um, uh, hyper to minimize the rise of glucose, which these drugs are going to very likely contribute to. Um, but it has not been, at least ketogenic diet for preventing antipsychotic induced weight gain has not been investigated yet. But worthwhile to, I think it stands, it's a reasonable theory. Uh, so my phone thought I said Siri. Um, let's move on to some now the specific topic of to what extent might a ketogenic diet have significant therapeutic benefit for symptoms of severe mental illness. Um, yeah, this is chronologically arranged. Kraft and Westman in 2009 had a case report. They describe a woman who was 60-ish years old. If I mean, I didn't reread this paper last night, but going by memory, my impression was that the patient in question was between 50 and 70 years old, and had had nearly continuous hallucinations for most of her adult life, which had not responded very well to various medications. She remained engaged in psychiatric treatment, but was struggling continuously. And according to the case report, she wanted to take some action on the weight that she had gained, and so came up with the idea of eating basically ground beef and tomatoes and lettuce, um, and that is a very low carbohydrate diet. So she more or less intuited a diet which would be in line with ketogenic diet. And she had then a complete resolution, a durable complete resolution of her multi-decade symptoms when she was on that diet. Then Palmer in 2017 reported on two patients with schizoaffective disorder who went on ketogenic diet and had substantial and durable reduction of their psychosis symptoms. There was a report from Brazil in which, interestingly, fraternal twins with treatment-resistant schizophrenia, which to my mind suggests heavy genetic loading or perhaps something that isn't schizophrenia, they had modest improvements in their psychiatric symptoms as recorded by the PANSS scale, but it wasn't their response wasn't nearly as good as those described by Palmer and Weissman. Nonetheless, the symptoms reverted and actually got somewhat worse after they went back to standard diet. And in Shamil, recently described a patient with rapid cycling bipolar disorder who had um, full remission of his symptoms when moving on ketogenic diet. So those are case reports of people with severe mental illness getting better with ketogenic diet. There was this study published by a group working in Sweden in 1965. This was a group, I mean, this was a prospective study without a control group. It involved 10 women with long-term schizophrenia, one paranoid, and nine said to be undifferentiated using DSM-3 terminology for symptom description. They had been treatment resistant. They all got ketogenic diet. The investigators did use a rating scale to capture symptom severity and found that after 2 weeks, there was a significant reduction of average psychosis symptom score in this group, and that when they stopped the diet, the scores reverted to actually shot past their baseline. So, uncontrolled prospective group study, small scale, suggesting benefit from a ketogenic diet. And then more recently, Danan and colleagues uh, working from France looked at this is a relatively somewhat complicated design. They identified 31 patients from an outpatient practice, and all 31 patients had very poor response to evidence-based medications. They had a variety of diagnoses: bipolar, schizoaffective, and major depression disorder. And they were then, I guess, recruited from the outpatient practice, invited to go to a hospital where a ketogenic diet was provided or initiated, and then either maintained as an outpatient or maintained in the hospital. There was a fairly high completion rate of 28 of those with schizo, actually, and then most patients got better. Focusing on the ones with schizoaffective symptoms, there was this is a very big reduction of PANS from 91 to 49. Keep in mind that PANS is a 31 item scale with each item having a minimum score of 1. So you cannot score lower than 31 on a PANS. So to go to 49 is a really substantial improvement. And 96% of them lost a significant amount of weight with average of 7 pounds. Looking at clinical global impression of illness severity, here are interestingly 28 completed, but they only report 27 on this graph. But you can see using clinical global impression, there was a trend for improvement for everybody, with limitations that there's not a control group in this study either. And there were things like being in a controlled environment in the hospital for most patients. Patients that were in the study wanted to be in the study. So is lacking in many aspects, but still that's a pretty impressive pattern of response. So we're left now with a treatment that is not a drug and is not patented and is a bit difficult to implement. And if you want to do a controlled, a controlled parallel group prospective study, it's going to be complex and expensive. So I'm not foreseeing a whole lot of movement in this area, which is unfortunate because my personal interpretation is that this diet probably works for a subset or a certain number of people with severe mental illness that looks like schizophrenia or bipolar disorder. Probably it doesn't work for everybody, and we don't have nearly enough data to say, to say the likelihood of response. So you can't say that 10% or 40% or 80% of people who start a ketogenic diet are going to get better with it. We simply can't make that kind of forecast yet, but it seems to be of some use for somebody and might be worthwhile to keep in mind. And I will stop this share now and move on for, well, to the next.